Yeah, Kannan sir.
Yeah.
Yeah, okay now, sir. It is open for delegates. Can we start, sir?
Yes, please.
Yeah, thank you, sir. Good evening, doctors. On behalf of Alchem Laboratories, India's fifth largest pharmaceutical company, I'm Balaji. Take great pleasure in welcoming all the eminent doctors who have joined us for today's panel discussion. Doctor, today's panel discussion will be on titled Galaxy of Experience on Rosuvastatin. Doctor, at Alchem, it has always been our endeavor to partner with healthcare professionals, and we will continue to do so even in these challenging times. To help us to navigate through the entire meeting, we have with us today Dr. B.R.J. Kannan sir, who will be our moderator for today's panel discussion. Welcome, sir. I take this opportunity to give a short introduction about our moderator B.R.J. Kannan sir. Dr. B.R.J. Kannan sir is a senior consultant interventional cardiologist who is practicing at Madurai. Doctor is currently head of the Department of Cardiology and clinical director at Badamalian Hospital, Madurai. Doctor has got 22 years of clinical and academic experience, and doctor's prime areas of interest are in teaching and in pediatric cardiology and interventional cardiology. Doctor is a recipient of various awards and medals. Doctor has got Commonwealth Fellowship Award and Best Challenging Case Award in TIC, as well as doctor has got many publications, close to 20 publications. Doctor has got on its name, and also doctor has authored more than 12 chapters in various books. With this short introduction, I welcome once again Dr. Kannan sir. Welcome, sir.
Thank you.
And I take this opportunity to welcome all the panelists. Firstly, like to welcome Dr. Ashokan sir. Dr. Ashokan sir is a senior consultant diabetologist who is practicing at Madurai. Doctor is associated with the Silva's Diabetes Care Center, Madurai. Doctor is also a visiting consultant at Vadamalian Hospital, Madurai. Doctor has got various research papers in APA conferences, Southern Chapter, and he has conducted more than 100 diabetic camps, and he has also attended various national and international conferences in the field of diabetology. With this short introduction, I welcome Ashokan sir. Welcome, sir.
Thank you.
Take this opportunity to welcome the next panelist, Dr. Ernest Prasad sir. Dr. Ernest Prasad sir is a senior consultant diabetologist who is practicing at Trichy. Doctor is currently associated with IES Nursing Home, Trichy, his own nursing home, as a consultant diabetologist in Trichy, and he is practicing since 1989 in Trichy. He is a managing director as well as a diabetologist at IES Nursing Home. Doctor's areas of special interest in diabetology primarily and hypertension, metabolic syndrome, and CAD. He has presented various papers in national and international forums. Also, doctor is a recipient of various awards, as well as he was holding many positions in the field of diabetology associations. He was a former secretary and chairman of Trichy API, and also a former secretary and chairman of Diabetes Club of Tiruchirappalli. With this short introduction, I welcome Prasad sir. Welcome, sir. We take this opportunity to welcome the next panelist, Dr. Ganesan sir. Dr. Ganesan sir is a senior consultant interventional cardiologist who is practicing at Madurai. Doctor is head of the department of Meenakshi Mission Hospital and Research Center, Madurai. Dr. prime interest is on clinical cardiology and in electrocardiology as well as interventional cardiology. And doctor is practicing at Meenakshi Mission Hospital right from 2012. And he has been a recipient of many awards, and he has been presented many papers in the field of cardiology and interventional cardiology. With this short introduction, I welcome Ganesan sir. Welcome, sir.
Thank you. Welcome, team, for this opportunity.
Let me take the opportunity to welcome the next panelist, Dr. Suraj Narasimhan sir. Suraj Narasimhan sir is a consultant interventional cardiologist who is practicing at Trichy. Doctor is currently associated with Kaveri Medical Heart City and Kaveri Hospital at Trichy. Welcome, sir. So with this short introduction of panelists, I'll hand over the session to our moderator, Kannan sir. Sir, you can set the context for the webinar. Over to you, sir.
Right. So, good evening, everyone. As I said earlier, it's going to be a very casual way of discussion. We are going to share our experience with this molecule. Now, whenever I discuss regarding any particular molecule, generally I remind the audience that whenever a new molecule comes with excellent efficacy, there will be a lot of hype. So in the first 1 to 3 years, we will be having a lot of papers regarding efficacy. It is highly efficacious. But however, the studies would not have seen the long-term side effects, because most of the studies that follow would have been 1 year, 1.5 years, 2 years, or at the maximum 3 years. So long-term side effects will start coming up after 3 years, 5 years, 6 years, and things like that. So if a molecule has stood the test of time for 10 years, that means that molecule is going to stay forever. That means by the time the effects would have been very well got established, and the side effects, even if it was not evident earlier, would have become evident. And hence, if any molecule is there in the clinical use for more than 10 years, most probably that molecule is going to stay forever, unless there is another better molecule as compared to this molecule. So in that way, statins are there for more than 22 years, to my knowledge. I know when I was doing DM cardiology in 1999, at that point, atorvastatin was introduced, not rosuvastatin. And 10 milligram of atorvastatin was 27 rupees. And it was a very high cost for 10 milligram. So my HOD was kind of jokingly telling, we should ask everyone to have to take atorvastatin so that they won't have any amount of money left for eating and they don't develop any CAD. Like jokingly he was telling. Subsequently, we had a lot of genetics and it became very easily available. And we all have been very comfortable in having used multiple statins, starting from lower statin. Our experience started with lower statin. Okay. Then we had simvastatin. Then we had atorvastatin, and now we have rosuvastatin and of course pitavastatin. Okay. With this background, I'm just going to ask in general. Today we are specifically going to discuss rosuvastatin. And in your practice, all my panelists, what percentage of patients are on rosuvastatin and what percentage are on atorvastatin? Dr. Ashokan, sir.
See, roughly around 60 to 70% patients are on rosuvastatin, sir. I'm using only some 40% atorvastatin, sir. 40% of patients on atorvastatin. Major chunk of patients on rosuvastatin.
Good. Dr. Ganesan?
Yeah, maybe opposite. I will be using atorvastatin in 60%. Maybe 30 to 40% will be rosuvastatin.
Okay. So Dr. Prasad?
Around 70% rosuvastatin, 30% atorvastatin.
Okay. Then I don't see Suraj is there. Yeah, Dr. Suraj?
Around 70 to 80% rosuvastatin, sir. 20 to 30% atorvastatin. And other than these two, that pitavastatin I use only for patient who has myalgia or who are not able to tolerate. Only these 3 statins I use. Other than that, no other statins I use.
Correct. Now, see, there was a clear-cut difference. Now, I go with, Ganesan, where 60% is some atorvastatin and 30-40% is rosuvastatin. So, Ganesan and myself are on one side, Dr. Prasad and Ashokan are on the other side. Probably Suraj is in the midway. Now this itself tells a very clear difference. Dr. Prasad and Ashokan are seeing primarily in the primordial prevention mode. They are having patients of diabetics, and they don't want their diabetic patients to develop cardiovascular disease. And hence, naturally, they have chosen rosuvastatin because more number of studies are stronger studies are there for rosuvastatin.
For primary prevention.
Yeah, whereas we, like you, me, and Dr. Ganesh and all, we are having more amount of patients who have had a ASVD, and where we have been quite comfortable with atorvastatin. So if you see, actually, effect-wise, there is no gross difference, but usage-wise, there could be some difference, and tolerability-wise, there could be some difference. Now, again, I'm going to ask question to Dr. Suraj. What do we call as high-intensity statin, and what do we call as moderate-intensity statin?
When we require a more than 50% reduction in LDL from the baseline, then it is a high intensity. Moderate intensity is around 30 to 50%. Because since most of our patients are having an MI or had an MI or having a atherosclerosis, so all our patients will come under a high risk group and they will require a high intensity statin. So 20 to 40 milligram of rosuvastatin or 40 to 80 milligram of atorvastatin. So these come under the high risk.
Okay, indication will come. So the high intensity statin is where we want the LDL to come down to more than 50% from the baseline. That's important that we should have a baseline LDL. Why is it? Because see, many times when we have acute myocardial infarction, somebody comes, most of the time you see LDL may not be high. LDL may be 120, even LDL may be 80, 70, but they would have come with acute myocardial infarction. We start the high intensity statin, and then when we check, we have some number, and we don't have any way to check whether what was his basal. Anyway, our patient is an established MI patient, and we continue on the high dose, high intensity statin. Anyway, so high intensity statin is more than 50% reduction from the baseline, moderate is 30 to 50, and less than 30% is the low intensity statin. In the current indication, low intensity statin hardly anyone uses. Okay, either it is moderate intensity statin or high intensity statin. So like Dr. Ashokan and Dr. Prasad, like in your practice, how many percentage people are getting high intensity statin?
Yeah, patients with other comorbidities, just plain diabetes, without any other evidence of atherosclerotic vascular disease or CKD, we use moderate intensity statin. Rest of the people, diabetes with atherosclerotic vascular disease or CKD or any other complications, we put them on high intensity statin. If you just see, maybe we'll see around 60-40. 60% of the people might be without any much of comorbidities, but at least they'll be having hypertension. Diabetes with hypertension, most of 60% of the people will be having. Maybe 40% will be having other comorbidities. Mostly they'll be having coronary artery disease. Yeah, I would say you should be also be doing 60% of our diabetic patients are definitely having some form of coronary artery disease or other. So right. If you just take all diabetic per se, because many of them come early, 30s, in the 30s and 40s now we are seeing a lot of diabetic patients, and only after their 40s, most of them they develop, other complications. So the percentage of people having moderate intensity statin will be more than that of the percentage of people who will be getting high intensity statin.
Right. Yeah.
My opinion in this is yes, any diabetic patient with the post-cardiac event, I would like to go for high intensity statin, and that too for 3 to 6 months, depending upon the lipid levels. I don't hold on to high intensity statin for a long time. I like to put the patient on moderate dosage of either atorvastatin or rosuvastatin, depending upon the patient's, well-being, something like that, and lipid profile. I don't hold on to high intensity statin for longer times, maximum 6 months. Otherwise, I taper down to normal levels.
Okay. Now it boils down to Dr. Ganesh, and see, There are three very definite indications for high intensity statin. One is established atherosclerotic cardiovascular disease. Cardiovascular disease means a history of stroke, carotid plaque, peripheral arterial disease, MI, everything inclusive of. Second thing is diabetics in whom the estimated risk is more than 7.5% over the next 10 years. I'll come to the 7.5%, why they arrived at this number. Third thing is if the baseline LDL is more than 190 milligrams per percent, which is very rare. In my practice, I rarely see LDL of more than 190, maybe 1% per year. These are the 3% who need high intensity statin. Now, coming to Dr. Ganesan, Dr. Asokan said he'll give for 3 to 6 months and then he'll come down to moderate intensity. Now, Dr. Ganesan, can you define what will be the dose that will be called as high intensity statin?
Yeah, if you the commonly used statins in our practice will be rosuvastatin and atorvastatin. So rosuvastatins should be 20 and above. 20 and 40 will be called the high intensity statins, and atorvastatin is 40 and 80. So those will be considered as a moderate intensity statins. Yeah.
Okay. So for the audience, let me tell that there is no other statin other than atorvastatin and rosuvastatin which comes under high intensity statin.
Yeah.
All the other statins come only under moderate intensity statins or the low intensity statins. So for us to decide, or if at all you decide to give high intensity statin, right now we have only two, that is rosuvastatin and atorvastatin. And if you see here, it's not one number, it's basically 20 to 40 milligram of rosuvastatin or 40 to 80 milligram of atorvastatin. And many times when somebody comes to acute event, we generally give the maximum dose. 80 milligram of atorvastatin or 40 milligram rosuvastatin. Currently, like slowly we are going to more towards the 40 milligram rosuvastatin. And after some time, if somebody wants to reduce the drug, we can reduce the drug to 20, still he'll be under high intensity statin. That's what I'm trying to say. This is in response to Dr. Asogan. After 1 year of the acute coronary syndrome, we can come down from dual antiplatelets to single antiplatelets, or you can continue dual antiplatelets for another 18 months or so. There are studies for that. From 80, you can come down to 40 of atorva, and for rosuvastatin from 42 can go to 20. And it's relatively economical. Currently, we have so many brands, including the Jupiros, which are not very kind of costly, affordable. They still be in the high intensity statin. Because as we have discussed, the high intensity statin is there for anybody who has established CVD. And hence the tolerable highest milligrams should be given. And I have seen that this 20 and 40 are very well tolerable for a long period, unless they come with further symptoms and unless there is significant reduction of LDL to less than 40, which generally doesn't occur. Moreover, earlier we had this problem of cost. Now that both the brands are available with a lot of generics, cost is not a factor. So can I have comments from you all, like this is 2040, coming down to 2040 after a year or so? Yeah, Dr. Suraj, you can start again.
Yes, sir, as you rightly told, so I am comfortable in reducing from 40 rosuvas to 20, but then I never reduce it below that. And if the patient was on atorvastatin, 80 to 40, that too, as you told, after a year or so, after an acute, even if it is an acute MI. If it is a chronic stable angina patient, probably I can do it after 3 months also, if the cost is an issue. But then I never go below that high intensity dose at all. So once he has proven atherosclerotic cardiovascular disease or atherosclerotic disease, then it is always a high intensity statin. So I never reduce it below 20 of rosuvas or 40 of atorvas. So that is what I usually practice, unless the patient is having significant symptoms of myalgia or if is not able to tolerate, then probably I might go down to 10. And also I'll side by side I'll look at the lipid profile also 3 to 6 months once. And if the LDL level is going very much low, below 30 or so, it is very rarely it happens. But then if it is so, then probably I might try to reduce it a bit. But otherwise, all my cardiac patients, I keep on high intensity statin lifelong.
Now, again, this question anyone can take. Maybe Ganesan will be in a better position to answer. Why do we need high intensity statin? Is there an advantage in continuing high intensity statin as compared to moderate intensity statin? Does it do anything to the plaque? High intensity statin does it have any effect on the plaque?
Yes, it reduces the lipid core. and also it stabilizes the plaque, and it has a role in the reducing the intima medial thickness also.
Yes, sir. As you rightly perfectly said, this high intensity statin only has shown stabilization of plaque or regression of the plaque. Moderate intensity statins can stabilize the plaque, may prevent the further events, but the regression has been shown only with the high intensity statin. Say there was a good study called Asteroid study, ASTROID. It was relatively kind of, it came in 2008, I think, 7, 8. It was done with IVUS, intravascular ultrasound. They, after starting therapy, after 1 year, they repeated the IVUS in those patients, and they showed that the plaques are regressing if you give high intensity statin. So there is an advantage of high intensity statin. But whenever you give high intensity statin, there is a trade-off, no? Of all the side effects, which is really worrying us, is the development of diabetes. And when it comes to that, okay, we have so many statins, say atorvastatin, rosuvastatin. I don't know whether we have pravastatin here. We have pravastatin, we have simvastatin, we have pitavastatin. Of these statins, which one is having least influence on the sugar levels? Dr. Ganesan.
Yeah, pitavastatin. I think now we have a data coming from some trials. They have shown that pitavastatin is the least we call it the new onset diabetes mellitus, NODM. Comparing, initially they thought it is a class effect, but of late they have found out that from the studies done in East Asian population and various people, that pitavastatin has the least chance of having new onset diabetes when the patients are followed for 2-3 years like that.
Right. So, okay. See, earlier they were, what the reason they were telling, pitavastatin is anyway not a high intensity statin, is only a moderate intensity statin. That's why you're not getting a high incidence of diabetes. As Ganesan has rightly said, that's not the only reason. That may be one of the reasons. There are other several reasons. The pravastatin and pitavastatin, they do not act through cytochrome pathways. Whereas the atorvastatin and rosuvastatin act through cytochrome pathways. Because of this, there is a link between the action on cytochrome pathway and the induction of the diabetes mellitus. And hence, they said whenever somebody is prone to develop diabetes, or there is somebody has high risk of diabetes, these statins advance the diabetes. See, there's a very clear study based on Jupiter alone. Whenever in Jupiter they use rosuvastatin in patients who already have established risk factors for diabetes, the diabetes got advanced by 1.5 years. Whereas when they again further divided the patients who did not have risk factor for diabetes, no family history of diabetes, not obese, otherwise active persons, there was no higher incidence of diabetes. So it again tells that it is going to bring in the sugar levels a bit earlier than what it was supposed to be with rosuvastatin or with any statin. There is no difference in this aspect, whether it's atorvastatin or rosuvastatin. Almost all the statins are having the same amount of effect, except this pravastatin and pitavastatin, both P's, pravastatin, pitavastatin. In their studies, they showed that either the diabetes is not increased or slightly lesser number as compared to other statins. So in a given patient, if somebody is really worried about diabetes, maybe one can shift over to, that's the only advantage of pitavastatin. Just to, there is 18% increase in the risk of diabetes, relative risk, 18% relative risk of increase in diabetes versus 33% reduction of MI, 38% reduction of the new onset revascularization, 25% reduction of stroke, and 14% reduction of total mortality. So when you put together all these so many good effects, 18% increase in number of diabetics, it's not that they immediately have developed CVD. The sugar levels have increased. So the benefit versus risk grossly is in favor of statin. There is no doubt. That's why we just continue the statin therapy. Now, so secondary treatment, there is absolutely no issues. All of us are using rosuvastatin. We are very comfortable. Now I'm coming back to Dr. Prasad and Dr. Asokan, very commonly primary prevention. Other than diabetics, do we consider giving statins as primary prevention? Dr. Prasad, please.
Yeah,
Yes, you tell about diabetes, how do you decide? And you tell about other non-diabetics, how do you decide?
Yeah, in non-diabetic people with a family history of premature coronary artery disease, if it's going to be in the family, then that is one candidate whom we consider initiating statin for primary prevention.
Okay. Like, we'll try
Yeah,
to.
because family history of premature coronary artery disease, if it is going to exist in the family, then along with that, his patient's lipid profile also is going to be altered. If that is the case, then definitely we initiate the patient on statin.
Yeah. A diabetic, anybody more than 40 becomes an indication for primary prophylaxis.
Yes.
That everybody has accepted.
Yes, irrespective of the lipid levels,
Yes.
if the
If
patient is
somebody-
above 40, definitely we put the
Exactly.
patient on moderate
If somebody
intensity
is
statin.
between 40 to 75 but not diabetic,
Yes.
then as you said, the LDL score is high, more than depending on the background. If the 10-year calculated risk is more than 5%, that be depending on the background, family history, and so many other things. So overall, when we calculate, as I said, for the high risk statin, sorry, the high intensity statin, we put up a number called 7.5%. If the 10-year risk is more than 7.5%, he qualifies for a high intensity statin. Whereas the 10-year risk is more than 5, he qualifies for the primary prevention, even if the patient is not having any dyslipidemia or not having any. So for primary prevention, we have to be much more careful. We have to have much more data to convince the patient to start it. In secondary prevention, patients do not ask us any doubt. They simply accept. Whereas in primary prevention, they'll say, definitely ask for it. So here also we should tell them that it reduces MI, stroke, all-cause mortality. The relative risk is in favor, and hence they need not worry. They can always take. Now that we have a very safe drug, as we have discussed, a simple 10 milligram of rosuvastatin is very good drug. It's extremely, somehow for primary prevention, I have seen many times people using 10 milligram of atorvastatin. I think they should go to 20 milligram of atorvastatin and stay with 10 milligram of rosuvastatin for us to have significant effect of the primary prevention, and this will not cause any increase in the harm. Now, there is a term called number needed to harm. Okay, there is a term called number needed to treat. Number needed to treat means is the number of patients we need to treat to get the benefit of one patient. Like number needed to harm is we need to treat 100 patients with moderate intensity statin to have one new onset diabetes mellitus. Okay, if moderate intensity. On the other hand, if it is a high intensity, we need to treat 33 to 35 patients to have one new onset diabetes. So that's why if you want to give high intensity, they have set the risk score as 7.5%, higher risk score, because there only the graph crosses. The benefit graph and the NNH graph crosses at the level of 30. That's why the 10-year risk score has to be more than 7.5%, 7.5% for us to consider high intensity statin. Whereas if the 10-year risk score is more than 5, then that is enough to start a moderate intensity statin, because there the number needed to harm is 100. So again, it goes on to the thinking that lower the statin dose, lower is the risk of the diabetes. So we can tell the relatives and convince them that it's very important to continue to take the statins. Okay.
Obesity
Now, yes.
Sorry to interrupt.
Yes,
obesity is yet another risk factor in the younger individuals whom they need a statin for primary prevention, because obesity has become as a common factor in our younger colleagues section.
Very actually. So generally, as you have said, who are the persons who are going to develop new onset diabetes mellitus? One is patient with metabolic syndrome. Second one, patient with known IGT, patient with a known who had a pregnancy-induced high glucose. Overweight patients per se are high risk for new onset diabetes, and elderly patients. So these are the patients, they need to be thought of to have ASVD later, and they should be kind of started on statins. Okay. Now, Dr. Suraj, we have been discussing the doses. In your experience, how many times you were forced to change the dose or stop the medicine, statin, because of the side effects? Of course, none of us will stop because of the new onset diabetes. We do not know whether it is because of the drug or whether in the natural history patient developed diabetes, isn't it? While on treatment, if the patient develops diabetes, we don't take that as a reason secondary to statin, we never stop statin, right? But on the other hand, can you tell us your other reasons?
So the usual reason for patient coming with statin and for reduction is myalgia, sir. So that is one thing which we normally find. And if you can do CPK levels, most of the time it will be normal only. But even then they complained of myalgia and leg pain and body pain. They typically complain when I sit down and when I get up, both my thighs are paining. That is especially post-MI patients who are on high dose 40 milligram of rosuvastatin, they complain of this. And I have almost never, one or two patients I have seen with SGOTPT elevation, but then it is very, very, very rare, even though they say it as liver enzymes can be altered with atorvastatin, but then we hardly do see that. And anyway, as you rightly told, even if the patient develops a new onset diabetes, we are going to treat the diabetes rather than stop the drug. So medicines will be continued. So in that case, what I do is in most of these patients, they have this vitamin D is on the lower side. So I check the vitamin D levels, and surprisingly, the same dose of statin, 40 milligram of rosuvastatin, when I correct the vitamin D deficiency, most of them, they don't even complain of anything. So first thing is I check the vitamin levels. If the vitamin levels are normal, and then I try to reduce it from half the dosage. It was 40, I come to 20, and then I try to maintain on that. Even if they are not able to tolerate, then probably we have to switch over to statin like pitavastatin. But the problem with this pitavastatin is never you can achieve the LDL goal with the pitavastatin alone. So that is for sure. If the patient was having a LDL of 70, I having myalgia, I stop the rosuvastatin or atorvastatin, I switch over to pitavastatin. Next 3 months, their LDL level will be 120 or 130 for sure, because their efficacy is not equivalent at all. So what I do is, whenever I start a pitavastatin, I always add ezetimibe. Even whatever may be the LDL, if I have to switch over from rosuvastatin or atorvastatin, if I start pitavastatin, invariably I add ezetimibe 10 milligram to that, because we very well know that the LDL is not going to get under control with pitavastatin. So main reason is myalgia, sir. And this rhabdomyolysis and all, I have mainly seen it the fibrates, gemfibrocil. I have seen recently a patient with started on gemfibrocil for a hypertriglyceridemia. Outside, he came with a typical rhabdomyolysis renal failure. But then I hardly do see elevations in CPKs more than 10 times upper limit. But then the pain is always there. So myalgia is there, but rhabdomyolysis is a little rare.
One practical observation which you observed is, suppose they are not able to tolerate, commonly we are using only atorvastatin and rosuvastatin. Suppose the patient is not able to tolerate atorvastatin, we change over to rosuvastatin. This myalgia, they don't complain much, or the other way around. So, that is one thing. Of course, as Dr. Suraj has said, along with that, to achieve the goal, we commonly add estimab. Now, a lot of studies have also come to show that it is also having beneficial effect in mortality reduction benefits and things and so forth. So this combination of either rosuvastatin with estimab or atorvastatin with estimab will definitely take care of both, the reduction in the risk as well as tackling the myalgia and other problems.
Correct. Sir, your experience, Dr. Ganesh and Dr. Asokan?
Sir, I didn't have much an experience to reduce the dosage of atorvastatin or stop the statin, because I have not seen a patient with myalgia, something like that, with the high intensity statin. Patients are able to tolerate it, sir. Our patients are able to tolerate, sir. Even if they complain of it, particularly of myalgia only, then I plan to reduce the dosage, sir. I don't have much of a patients with the typical myalgia with the high dose statin, sir. I have not experienced such things in my practice.
Good. Yeah, I think it has been slightly exaggerated, but many times it's only myalgia, and myositis is the one which is very dangerous, which is very rare. Dr. Ganesan, in your experience, any myositis or renal failure?
No, sir, I have not seen myositis so far. I think maybe we may underdiagnose sometimes, but very rare. I think in our practice, I have not seen any cases of myositis so far. Yeah, I have not stopped any statins because of liver function elevation also.
Exactly. See, earlier when it was brought in, atorvastatin, they said every 6 months you have to do liver function test. But subsequently, that recommendation has been taken off because it doesn't increase to that level. Even if there is an increase, it's going to be mild increase. It never increases to twice the upper limit of the normal. Okay. Just the
One more
other
thing.
fact. Yes, sir.
One more thing to add, Dr. BRJ.
Yes, sir.
Whenever the patient is on high dose statin, if they sustain an injury, actually RTA, something like that, I have seen lot of muscle injury. If they fall, they get a muscular edema that is doesn't subside within the stipulated time which we actually wanted to do.
Oh,
See, I have seen few patients who are on high dose statin who have sustained some injury. The muscular edema and the muscular pain, it persists for nearly a month.
okay.
It takes much of a time to go. I have seen it in few patients, 2 to 3 to be precise.
So
I
good
don't know
observation.
whether it's
The
due
good
to the muscle
observation.
injury or some rhabdomyolysis, something like that. I don't know.
Okay. So good observation, sir. We'll just see. See, advantage of what they project compared to rosuvastatin or compared to atorvastatin, what rosuvastatin has is that it is also reducing small dense LDL. Okay, as compared to other statins, it improves the arterial stiffness by mechanism which we do not know. As we have discussed by IVA studies and by MRI studies, carotid plaque regression, coronary plaque regression has been very well documented. And then one thing, there is a paper to tell that it reduces the mean platelet volume, because the platelet volume is related to the hypercoagulable state or hyper aggregation of the platelets. They say that rosuvastatin reduces the mean platelet volume. So these are the things which is mentioned as advantages of using rosuvastatin as compared to other drugs. Now, let us come to the relatively kind of, these are the usual discussions we have. Number one, we should have full confidence on using statin. It is there for more than 20 years. There is nothing to worry. And the benefit outweighs the risk. And even the risk also, we can clearly see which patients we can be more careful and things like that. There is no issues. And we have a very relatively safe statin. If all the 4-5 of us who are sitting here, I have not seen any major problem in spite of using in hundreds of patients. So though the patients come with some symptom, we can reduce the dose, number one, or we can change to some other preparation, as Dr. Prasad said, number two, or we can change to pitavastatin. But Suraj has very clearly said pitavastatin may not give that much of level as we aim at, so it's always better to combine AGT-MI. Okay, so now coming to the combinations, combination of the statin with some other one drug. The common drugs which are combined with statins are antiplatelets, isn't it? So we have triple drug combination where aspirin, clopidogrel, and statin, either rosuvastatin or atorvastatin. And then we have only aspirin, we have only clopidogrel. Now, what's the most favored combination? Beyond 1 year, I'm saying. Beyond 1 year, there are many patients who are under the follow-up for further prevention of the CVD, isn't it? Beyond 1 year. Up to 1 year, of course, all of us give statin, do a dual antiplatelet therapy and things like that. Beyond 1 year, I'm giving 4 choices. Rosuvastatin 10, aspirin 75. Rosuvastatin 20, aspirin 75. Atorvastatin 10, clopidogrel 75. Atorvastatin 20, clopidogrel 75, atorvastatin 40, clopidogrel 75. So of these 4 things, which is the best suited combination?
Be rosuvastatin 20 and aspirin 75.
75.
Yeah.
Okay. Because these are one available right now. That's why I used these numbers. Now, slowly we are shifting from aspirin to clopidogrel. In future, the maintenance therapy, clopidogrel may take over as compared to aspirin in future. And we are going to see more and more preparations of rosuva plus clopidogrel and atorva plus clopidogrel. But whether it's aspirin or clopidogrel, we need not go any number higher than 75. For aspirin, at the maximum, there was a study yesterday also in ACC that 81 milligram of aspirin is same as 325 milligram of aspirin. So there is no need to increase the dose. Same with clopidogrel. but the clopidogrel 750 milligram has very less gastric side effects as compared to aspirin, with the same efficacy or even a higher efficacy. So as a maintenance dose, there are at least 1 or 2 papers yesterday presented at ACC where clopidogrel was taking over the place of aspirin as the maintenance single antiplatelet agent as compared to the earlier days. Earlier days, the moment we stopped the dual antiplatelet, we were shifting to conventional to aspirin. Now in the place of aspirin, clopidogrel is slowly coming up. So this is the one combination along with this.
Yeah, even in our practical experience also, for our diabetic patients who are on, polypharmacy, multiple drugs, and especially who are on high dose of, metformin, either acarbose or voglibose. And then when we add aspirin, no, they are unable to tolerate. So mostly in diabetes with coronary artery disease, we prefer, clopidogrel with, rosuvastatin or atorvastatin, whatever it may be, rather than with aspirin.
Yes. Okay. Right.
I want to interrupt Kannan.
Yes,
Kannan, what's your opinion about aspirin resistance in Asians? And secondly, clopidogrel doesn't work well in females as that of aspirin when compared to aspirin. I want to have your take on this.
So the clopidogrel, so the aspirin resistance in general is higher than clopidogrel resistance. In general, aspirin resistance is higher than clopidogrel resistance, which we have not given notice, because it is the original drug which have been tested since years. There is a lot of confidence and a lot of papers on that. We continue as a baseline drug. Whenever people compare aspirin versus other antiplatelet like clopidogrel, they found always clopidogrel is better in their antiplatelet activity in the lab. Now there are papers coming with clinical papers. This difference between the gender, I do not know, sir. Whether it's better in females and males, we do not know. But it is true.
Clopidogrel doesn't work well in females.
Okay.
When compared to male gender, that's what they say. And aspirin is much preferred in females when compared to males.
Okay, maybe we can look into that. But in general, now currently, whenever we try to combine the drugs, only the antiplatelets and statins have been in combination. There are some preparations where the statins have been combined with telmisartan, right? There are some preparations with telmisartan. Can Dr. Ganesan discuss something on this combination?
Which one, sir?
Telmisartan plus statin.
Yeah, this also being routinely used now in patients. I think not because most of the patients will need a what we call is a drug, which now we need apart from BP reducing, we need a drug which acts on the other like a pleiotropic like effect. So the ARBs are the one which is now they are thinking, and this combination is also I'm not fully able to answer. I think Kanan sir, you can add on that this added benefit. You should if you put it in a simple word. Now wicket keepers like Rishabh are more favored than a solid simple batsman who can bat alone or bowl alone. So multi pleiotropic effect is the one which is going to play a major role in the so that we can reduce a polypharmacy. That may be a basis why we need a drug like rosuvastatin, which is also considered as a powerful drug with a various pleiotropic effect, and telmisartan also. Even the new molecule which is coming into the market, SGLT2 inhibitors, I think it's out of scope of today's meeting. But these are the molecule which is going to play a major role in the days to come, I think.
Like basically, as a primary prevention, as we were discussing rosuvastatin for primary prevention, as a primary prevention drug for diabetics, this telmisartan has been recommended, not because of its anti-hypertensive effect, because of its CV reduction effect. Of course, ramipril has been indicated. So there are combinations with CARDACE, ramipril. There are combinations with telmisartan. Both can be given in patients even without hypertension, especially diabetics. Having this in mind, this we cannot measure it out exactly. Our aim is to reduce the future CVD, and if you believe in that, you can give. That's all. So when it comes to, I was just discussing what are the other drugs which have come in combination with atorvastatin. One is this ramipril and telmisartan on one side for primary prevention, and other side this rosuvastatin plus antiplatelets. So
Okay.
I think that should cover up with most of the topics on rosuvastatin. And we are almost 750, and they have got some other presentation from the company also. So if anything else to be discussed, I request our seniors and other my co-panelists to bring in the topic regarding statins.
Kanan, what is your opinion regarding the high intensity statins producing a sort of memory loss, cognitive dysfunction, something like that? Because our senior neurologist used to say
Repeatedly
that,
say.
see, I take his words actually. That's why I'm asking that. Because he used to say, don't go for intense statin therapy for long, and that too in people above the age of 45. It affects the nervous system, leading to cognitive dysfunction, memory loss in longer time. See, the diabetogenic part of it, it's acceptable and we can treat it. But this cognitive loss and memory loss, can it be reversed with stopping the statin? It's not understood even now. See, what's your opinion regarding that?
The first thing is I specifically look for it when I look for complications. First thing, it has not been proven. Now the initial fear was icy bleed regarding statin. That also did not was subsequently it was unproven that it doesn't cause icy bleed. Now we have the recent molecule called PCSK9 inhibitors.
Yes, sir.
These PCSK9 inhibitors are bringing down the LDL to 30 milligram percent, 40 milligram percent, which is seen in the neonatal period. You know, a neonate is the one which is utilizing maximum the lipids to growth of brain. Our brain achieves 90% of its size by 2 years. That's why if you see a child, the brain is much bigger as compared to the body. There's a very fast growth of the brain in the first 2 years. So in the first 2 years, the serum lipid level is only 30-40 milligram per deciliter. So this PCSK9 inhibitor reduces to that low level, 30-40 milligram percent. Still, in the 3-year follow-up, they couldn't show any CNS side effects in the form of dementia, memory loss, or in the form of any bleeding. So right now, the apprehension is there, but it has not been proven, sir. But as we discussed to start with in the initial period, in these individuals, especially elderly, when you are kind of concerned, whenever he himself says some kind of memory loss and things like that, we'll come down to the lower side. You know, it is not drug. See, for example, a person taking oral anticoagulation for a mitral valve replacement is a life and death situation. He can never stop. He can never reduce the dose. But statin is not like that. Okay, it's all a relative risk, right? Okay, for a given person, a 30 milligram, a 20 milligram of 10 milligram of rosuvastatin may be giving the same effect as 80 milligram of rosuvastatin also. You know, it's all multifactorial related issues. So in a given individual, we can always individualize, come to the lower dose and just continue. That's what I have been following. But this is unproven our doubts. This unproven apprehension that these molecules increase neurologic complications. Others can comment. Dr. Suraj, Dr. Ganesan, Dr. Prasad sir can please comment. This so-called memory loss, dementia induction by the statins. Have you seen clinically or have you read somewhere?
So till now, I have not seen any patient. But then the problem is, we cannot, even if the patient who's on statin who develops dementia, he has other risk factors which produces multiple infarcts in the brain that can also produce multi-infarct dementia. So the causative we cannot be sure, because most of the patients who are going to be on statin who are on old age will be having diabetes or hypertension. And whether it is just because of the statin take or it is because of small infarcts which has caused multi-infarct dementia, we cannot be very sure about what is the reason. So till now, I am not had a clinical experience of patient who was complaining of dementia because of high dose statins.
Correct. Correct.
Yeah, very difficult to prove.
Yes, sir. Right. So I think we had a fairly all-around discussion about rosuvastatin. So my sincere thanks to Dr. Asogan, Dr. Prasad, who are quite very seniors, my colleague, dear friend Dr. Ganesan, and also my dear friend Dr. Suraj for joining with me for the discussion on Jupiros. I also thank Alcom for arranging this meeting and hope the listeners got their queries clarified and they are much more confident in using this molecule than before. Thank you very much.
Thank you.
Okay, sir. Thank you,
Thank you.
sir.
Thank
Before
you.
giving the closing remarks, I like to take a small take this opportunity to present a small 4 slides on Connect to Clinic, which will be more helpful for doctors in these challenging times. So I'll just share the screen, sir.
Yeah, please go ahead.
Yes, sir. Yeah, sir, can you able to see the screen, sir? Connect to
Yeah,
Clinic.
we are seeing clearly. No problem.
Thank you, sir. Thank you. Sir, Connect to Clinic is a simple, secure, and reliable telemedicine platform, which is 100% medical legally compliant. And it is a virtual clinic which is helping the doctors and patients to have a connect with the both of them during this challenging times, sir. So Connect to Clinic, sir, it is as I said, it's a medical legally compliant. It is compliant with the latest teleconsultation guideline of NMC, and it is also highly secured, data safety, and is completely secured. It is as per international standard, HIPAA standard maintained. So there will not be any issues on data safety and security. Also, in Connect to Clinic, there is accessing patient history is very easy for doctors, so which can help doctors during teleconsultation. And also payments, it is the speediest payment compared with all other platforms which is available in the industry. Also, the scheduling part is very easy, and doctors giving prescription, doctors can give both e-prescription as well as handwritten prescriptions, which is again compatible. It is very easier for doctors, and also a 24/7 customer care support is available with Connect to Clinic. Sir, currently doctors are some doctors, they may use WhatsApp consultation because of the challenging time which we are having. But with the WhatsApp consultation, there is a high risk on data safety and security because bank account and card details now because of the revised guideline of WhatsApp. So these details can be taken up by WhatsApp. So data safety and it is highly risk now. And also doctor location, contacts, and pictures can be taken. Also the interaction which is happening between the patients, again, it can be accessed by the app application platform people. Also the diagnostic details which is happening again can be taken up. Also the device and connection specific information can be taken up. But Connect to Clinic is completely secure. Here are some features compared with the existing available platforms where Connect to Clinic is found to be superior one. First, the part is service charges. Compared with the all other service charges which is there in the industry, Connect to Clinic has got the lowest service charges, which is only 6% to the patient, which is the lowest in the industry, where other platforms are much higher. Also, patient consulting support is high quality videos are available with Connect to Clinic, which doctors can share to the patient. So, which can help again in terms of patient education videos can be easily viewed by the patient. And again, in terms of complaint sake, this will be more helpful. Payment part, as I mentioned, it is within 24 hours. Connect to Clinic. This is the only one application which is available. All other platforms, it is taking more than 24 hours. And also complimentary promotion is available with Connect to Clinic, and it is not a marketplace for the doctor, unlike other platform which is available. So it is completely secure and reliable platform which is available. So to understand more usage of Connect to Clinic, so you can get in touch with our Alchem team people, sir. So any one of our Alchem team member can help you in this regard, in establishing Connect to Clinic in your clinic. Thank you, sir. So let me take this opportunity to give a closing remarks for today's meeting. So firstly, I'd like to take this opportunity to thank Dr. B.R.J. Kannan, sir, for accepting our invitation and moderating the panel discussion today. And also, I'd like to thank all the panelists, Dr. Ashokan sir, Ganesan sir, Dr. Prasad sir, and Surat sir, for sharing a clinical experience on rosuvastatin in the clinical practice. And also, we'd like to thank all the doctors who have joined us for today's panel discussion. And I'm sure all the doctors will be appreciating the experience which has been shared by our panelists today. at this juncture, we like to salute all the doctors and paramedicals who have contributed immensely for keeping us all safe and healthy in these challenging times. Sir, we at Talcum Laboratories will continue to serve doctors and patients by making our products available, especially our chronic brands Jupiros, Volcom, and Blue Wilda. So thank you, sir. Thank you once again. Thanks for the opportunity given, sir. Thanks, sir. Have a nice evening, sir.
Thank you. Thank you, everyone. Thank you.
Thank you, sir.
Thank you, sir.
Thank you. Thank you. Bye.
Thank you. Thank you. Bye bye.
Thanks, sir. Thank Ganesan, sir. Thank you, sir.